It now gives me great pleasure to introduce Angela Mayo. She's a PA who works at the Mayo Clinic, and I suspect she sees more myeloma patients than anybody and has the most expertise. And she certainly makes life better for all of our patients.
Thank you. It's nice to be here today, and I see a lot of familiar faces out in the crowd, and that always is optimistic and makes me happy to see patients and family members and caregivers out here looking good and learning things and doing well. So we've had a lot going on. You've had a lot of really interesting information. You've had some lunch. Now for a minute, we're going to get you involved and have you answer this question. So when you were diagnosed with multiple myeloma, tell us what kind of symptoms, if any, you had. Okay, so there's a wide variety of symptoms. It seems like the most common thing that I'm seeing over here is bone pain, and those are the stories that I hear from patients as well. Something hurt, they didn't know why, it didn't get better, they tried conservative management. Somehow somebody starts looking into this bone pain and finds some lytic lesions. A fair percentage of people, about 20%, said they had low blood counts as well, which were identified. Poor kidney function in a lesser percentage of people at the time they were diagnosed. Many people have some of these symptoms, and a good portion of people really don't have any symptoms at all. Some people tell me they were diagnosed because they were going through a routine physical, and an astute clinician noticed that something was going on that wasn't quite right. An elevated total protein, maybe a mild anemia, maybe something subtle that let them know what was happening. So now we're going to talk, so we've talked about all the exciting advances, we've talked about effective ways to treat people. If we can't keep you on your treatment, then we can't do very well for you. And so we're looking at how to improve your quality of life when you're on treatment, how to improve your quality of life with myeloma in general, and what are some of the ways that myeloma harms you, what are some of the ways treatment can harm you, and how can we work on those. So how many of you are familiar with the CRAB criteria? Probably a fair number. I know some educated folks in this audience. The CRAB criteria are traditionally used to describe the ways that myeloma hurts somebody. The C being calcium. Your calcium can become elevated in your blood. The R becoming renal, and so they show the decreased kidney function here. A meaning anemia or other low blood counts, and B being bone damage. So those are the traditional ways in which myeloma harms your body. So we'll start by talking about bone disease, which was described fairly often in our poll that many of you experienced that. It does occur at some point in 85% of myeloma patients. And so the bone becomes weakened and lesions form there. When those lesions happen, this is sometimes how the high calcium can come about too. The calcium goes out of your bone and goes into your bloodstream and can cause some very, very serious effects, as people are quite ill when their calcium is high. Also, it leads to fractures. It can lead to problems with your spinal cord, compression of your spinal cord, even serious things such as paralysis. Pathologic fracture is one thing that we hear a lot. Sometimes somebody breaks a bone seemingly for no reason, and it's because myeloma has been in there doing damage. And so if you look at those pictures, they show a fracture caused by a lesion, and then they show those lesions are those punched out areas in the bone. And the other image shows a skull, which shows those darker areas are lytic lesions in the skull. Surprisingly, those are quite common and often don't cause patients a lot of symptoms, but the myeloma tends to affect those flat bones in the skull quite often. So ways that we treat bone disease, the standard that we have used for quite some time is bisphosphonate therapy. Bisphosphonate therapy would be Iridia or Zometa, pamidronate or zoledronic acid, and those are IV infusions. They prevent the bone disease from getting worse. So what happens when there's myeloma bone disease is that the bone is, normally there's a process that happens where your bone breaks down and then your bone repairs itself. And in normal bone, that happens at kind of a nice even pace. In myeloma, what happens is that the bone's breaking down very rapidly and the repair mechanism is not there. And so we're going to try to help. We're going to try to help decrease pain, reduce the likelihood of you having a fracture. So you'll receive this as an IV infusion in the office approximately every 4 weeks. So we've got the zoledronic acid or Zometa, which takes about 15 minutes to give. We've got the pamidronate or Iridia, which is a little lengthier infusion. It's a 2-hour infusion. So these are good drugs to help your bone health. Some of the side effects and some of the things we have to look out for is if you have impaired kidney function, we have to adjust your dose, or sometimes we even have to omit this medication. And as we talked about, low kidney function is one of the hallmarks of myeloma for a good number of patients. So if you have impaired kidneys, you may not be eligible for this drug, or you may need to use it in a modified fashion. There are some potential fractures that could be more likely to happen, such as some fractures of your femur and your hips. And then there's osteonecrosis of the jaw. It's not extremely common, but it's common enough that we do see it happen. So your jawbone can actually develop this necrosis and die. It can become painful. Usually that manifests in some exposed bone in your jaw. So those are some things that we do have to look out for when we're giving this therapy. Therefore, we recommend some oral health preventative measures prior to initiating bisphosphonates and if you're on these kind of therapies. So if you have any major dental work that needs to be done, get it out of the way before you start these infusions. You can wait a little while to start these infusions, but you want to have your oral health in the best possible state when you do that. Practice good oral hygiene and see the dentist regularly are things that you should do. Always let your dentist or oral surgeon know that you are receiving bisphosphonates or that you have received bisphosphonates, because if they need to do procedures, they may need to be more cautious with you as a result. It says it seems to be related to the length of time that patients are on bisphosphonates. So if you've had lots of bisphosphonate therapy, you may be at higher risk than if you've only had a small amount. Therefore, you also discuss with your physician and your treating team how long you've been on the bisphosphonate, what are the risks, what are the benefits, how should we structure that for future. The spine is often affected by multiple myeloma, and compression fractures can be very painful. They can limit your mobility, and they can be cause of needing narcotic pain medications. They can be very problematic. So there are some minimally invasive procedures that can be done in some patients. If you're an appropriate candidate for these, there's a vertebroplasty or a kyphoplasty. So it shows the vertebroplasty on the left. These are outpatient procedures. We do it in our facility, they do it in the interventional radiology department. So they'll look at the right place to go, and they'll inject their instrument, and they'll take a cement filler and put it into this damaged vertebrae to stabilize it and make it stronger. The kyphoplasty is similar, but there's also a balloon that's involved. They blow up this balloon to try to restore the height between those vertebrae, because when you have a compression fracture, they're smushed down. So we're trying to re-expand that again. And it does not help everybody, but if you're a person that it helps, it may have some pretty rapid relief in your pain. And so if you have a specific spot in your spine, you may be a candidate for one of these procedures. I've had some people, it says here approximately 1 month, but I've had some people tell me they felt better when they got off the table from having this procedure. So if you're the right person for it, it can be helpful. It's minimally invasive. You don't have to stay in the hospital for it. Radiation therapy can also be effective if you have a specific spot that's painful in your bone. Radiation is very effective at killing plasma cells or myeloma cells, and so they can target the radiation at the lesion and give you some good pain relief there. Now there's a new option that's been recently approved for multiple myeloma. It's called Xgeva or denosumab. So this is a new medication that works differently than the bisphosphonates. And it's also for multiple myeloma patients. So this diagram shows a little bit about how this drug became approved. They did a study, and they took patients who were newly diagnosed with multiple myeloma, and they randomized them. So they gave half of the people Xgeva and half of the people Zometa. When they do that, they do what's called a double-blinded study. So the patients don't know whether they're getting Xgeva or Zometa. The clinicians don't know whether they're getting Xgeva or Zometa. So I was reading about this, and so half of the patients got a saline infusion instead of their Zometa infusion, and then they got an injection, which was the Xgeva. Xgeva is a shot, so it's not an IV. The other half of the patients got a shot of, I don't know, saline, just a little bit of saline, and then some of them got the shot of the real thing. So you were getting both, but you didn't know which you were getting. Both of these are equally effective, and so this is how this got approved, that they were equally effective. It doesn't say Xgeva is better than Zometa, but it is at least as effective as Zometa. And it seemed to have fewer side effects related to kidney toxicity. So sometimes this might be an attractive option if you have renal impairment and if you need to have some treatment for your bones. So it's nice to have another tool in the chest for protecting your bones. Low blood counts, extremely common with myeloma. So depending on what cell lines are low will depend on what we call it. Low red blood cells is anemia. Low white blood cells is called neutropenia. or leukopenia, and low platelets is called thrombocytopenia. And so these have different constellation of symptoms and different reasons that we need to treat those. Often when people are diagnosed, they might have a lot of myeloma cells in their bone marrow. Their bone marrow is supposed to make good cells for them, and it's not able to do that because it has too much myeloma in there. So sometimes as we treat myeloma, blood counts actually get better. Some of our therapies can also cause low blood counts, so we might have a few things going on that affect people's blood counts. So the low red blood cell count, people who have this will identify right away when their hemoglobin is low. I have people come in and tell me what they think their hemoglobin is because they're tired when it goes low. So you'll have less energy, you may feel depressed or have mood changes, you may feel short of breath, you may not be able to do your normal physical activities. You may feel your heart beating fast. I just had someone the other day say, I could feel my heartbeat in my ear, and I just feel kind of short of breath. And we checked his hemoglobin, and lo and behold, it was low. You can have difficulty sleeping. There are other reasons where you could be have anemia besides myeloma. So we also might want to check things like iron and vitamin studies. If you're deficient in any of those things, then we can replace them. And then as far as treating, if we can find a cause other than myeloma, we can treat it. If you're low on iron, we can replace. If you're low on vitamins, we can replace those. There are some medications that we can use that stimulate your bone marrow to produce red blood cells. And we can use blood transfusions if the counts are low enough. Now, when we use a blood transfusion, it's a temporary fix. We'll be putting in some donated blood to replace what your marrow is not making. Ultimately, the best fix is if we can successfully treat your myeloma and free up that space in your bone marrow so your bone marrow can get back to a more normal function of making your red blood cells. And so that's why sometimes people's counts actually get better during treatment because their marrow is able to take over and do what it knows how to do anyway. Now, neutropenia is a low white blood cell count, and this becomes important because it puts you at risk for infection. And infection is very serious business for people with multiple myeloma and people on chemotherapy. It can put you in the hospital, it can put you in the intensive care unit, it can even be a life-threatening situation there. So we want to be mindful of neutropenia or low white blood cells. So you probably have those checked pretty frequently at your provider's office. There are certain vaccines that we may recommend for you. Now, if you've had a transplant, there may be a period of time that we have to wait, and then we re-immunize you against a lot of illnesses. If you haven't had a transplant, then we may just give you some standard. I tell all my patients I recommend that you all have a flu shot. I know the flu shot was not overly effective this year, but it still often is a very good protection. Things like pneumonia vaccines are very, very important because I have a high rate of people that get pneumonia with multiple myeloma. There may be other medications that we tell you to take depending on your situation and depending on your immune system and your treatment. Antivirals are pretty common. We use acyclovir or valcyclovir to prevent you from getting shingles. Shingles is just when we all had the chicken pox when we were kids. My son, he's 6, he's never going to get the chicken pox because they give immunizations against that now. But when we were growing up, they didn't do that. So you get the chicken pox, it goes dormant up to your nerve roots, and then when your immune system is under stress, it may come down one of those nerve roots and cause very, very painful blistery rash. So we may use some antiviral medications to keep this from happening. I would want to add here, though, when we're talking about shingles vaccines, make sure to discuss that with your healthcare team before you get it, because there are some shingles vaccines that we may not recommend for some patients. Sometimes we'll use preventative antibiotics. Sometimes we'll use them after transplant. Sometimes we'll use them when you're on certain kinds of treatment. Sometimes we do, sometimes we don't. We have to balance the risk and benefit on using those things. When we're going to treat a neutropenia, we can give you shots. We can give you a medication that will stimulate your marrow to produce more white blood cells. Thrombocytopenia is a low platelet count, and platelets are what helps our blood to clot and helps us to stop bleeding when we're supposed to. So if you don't have enough platelets, you may be at risk for bleeding. This can be real serious, and so if you have low platelets, I always tell you, don't fall, which is often easier said than done, but definitely take some precautions if your platelets are low. This may be superficial bleeding, like you have extra bruises, or it could be serious bleeding, like if you fell and hit your head, you could have bleeding in your brain. So depending on where your platelet count is, depends on what your risk is. We want to identify and treat. We want to see if there's anything else causing the low platelets that we can fix. We want to see if there's any illnesses that are making you have low platelet count. We can transfuse you if needed. When we're giving you certain treatments, we may thin your blood. When we're giving drugs like Revlimid and Pomalyst, we also often put you on a blood thinner so you don't get a clot. Well, if you don't have any platelets and we're also thinning your blood, it may end up being too much. So depending upon your platelet level, we might have to withhold those drugs that anticoagulate you. Decreased kidney function. So how do we know if someone has poor kidney function? In a severe case, they may not produce urine at all, or they may not produce very much urine. In a milder case, we might notice it in blood work. So we're going to always be checking your creatinine and see if you're having adequate kidney function. There are other things besides myeloma that can damage your kidneys. Hypertension and diabetes are very, very common illnesses, and they can cause kidney damage too. Certain medications can harm the kidneys. One of the most common things that harms kidneys that we use often, that we think of as benign, are anti-inflammatory drugs such as ibuprofen, Aleve, Advil, Motrin. We want to be careful with those drugs because they can be toxic to your kidneys, and if you already are carrying a lot of myeloma around with you and that's toxic to your kidneys, it can be a bad combination. So those aren't necessarily candy. Make sure to tell your providers if you're using a lot of those, and they may recommend something alternative if you're having pain that requires those meds. So if we give you a lot of fluids, often we can lower your creatinine, often we can improve your kidney function. If you have a lot of myeloma, we can even perform what's called plasmapheresis, where we take the proteins out that are causing your kidneys to be damaged. And in severe cases, you can be on dialysis. And so I do have patients who are on dialysis, which is definitely a challenge for them, but I have people who do very successfully on dialysis for a long time. Now, we talked about this a little bit in one of the earlier lectures, but we'll talk about a few of the side effects of some of the common therapies. And one is Velcade, and Velcade is known for peripheral neuropathy as being one of the side effects. So this image shows some pins in the foot. That's probably about what it feels like. People tell me how neuropathy feels is that it starts with some numbness and tingling usually. It starts at the tips of the toes and tends to move up your legs. It may be on the tips of your fingers and move up. It's usually bilateral. It's usually in both sides. And the neuropathy that comes from Velcade is what we call sensory neuropathy most of the time. It causes numbness, tingling, pain, rather than weakness, but it can cause weakness as well. We're talking about treating neuropathy. Somebody had said, is there a cure for neuropathy? Well, there's not. Neuropathy does get better. Often, as we get further out from the treatment, if you stop your Velcade, it may improve. But a lot of you can probably tell me, a lot of patients tell me they do have some residual neuropathy from their treatment. So one thing that's going to be important while you're on treatment is that you communicate about the neuropathy and what's happening, because we may be able to nip it in the bud and prevent it from getting that bad. And that's always the best thing, because once it's there, it may be with you for life in some form. There are lots of other things that you can try. I've had some people try things like acupuncture, physical therapy. I've had people try medications, neurology-type medications, gabapentin or Neurontin, Lyrica, Cymbalta. Some of those medications sometimes are used. There are some topical treatments that may work. Wearing supportive footwear is a must. If you have neuropathy, those high heels are going to have to go away for a while. And you don't want to fall. So if you're out doing things, if you hike, take a walking stick. If you're walking and you need some support, get that support. Because sometimes when you have neuropathy, your feet don't really tell you where you are in space, and you might be more likely to fall. If you have bone lesions and you're more likely to fall, we don't want that to happen. That could cause some problems for you. We can often modify your doses of treatment, or sometimes even we change your agents that we're treating you with if you're getting neuropathy, so don't be afraid to bring it up. Sometimes people don't bring it up because they want to get better. They don't want to jeopardize their treatment, but we don't want you to have something that's chronically painful if we can do without it. Revlimid, another commonly used oral chemotherapy drug that we use for myeloma, and some of the side effects that we hear for that. Rash, I'm going to start with rash. Rash is pretty common when people start Revlimid. Often we can get you through it, and after a while it may go away or get better. So if you're having a rash, you want to call in and tell your healthcare team. You may use something like Benadryl or Claritin, an over-the-counter antihistamine. You can use those topical creams like hydrocortisone or Benadryl creams. And you may possibly even need to see dermatology or take some oral steroids, some steroid pills. Often what we do is we'll often stop the therapy until the rash gets better and re-challenge. And sometimes after we've done that several times, we can get you through the Revlimid. If you get a rash the minute you take Revlimid, it doesn't necessarily mean you can never use that drug, but it means we might need to work a little harder to get you to use that drug safely and without a rash. Muscle cramps, Charlie horse type of pains are often things that people tell me they experience on Revlimid. Tonic water may help. It contains some quinine. Staying well hydrated in general is helpful, and gentle stretching or massage. Sometimes people have said things like heating pads can help. Make sure there's nothing else going on causing you to have those cramps, such as low potassium or other electrolyte problems. And sometimes you need a dose change if these problems are very severe. Diarrhea, don't you like that image? Not very fun. Ironically, some people have constipation, some people have diarrhea, but bowels. No one wants to talk about it, but it's serious. It can interfere with your quality of life, for one thing. I have people that don't want to go places because maybe the diarrhea will cause a problem. So please speak up about it. We're used to talking about diarrhea. I have a lot of patients. I have a son. I have 3 dogs. I'm used to talking about bodily functions all the time. But we can help it. Imodium sometimes can be helpful. There are other drugs like cholesterol, which bind up the bile acids in your system. And that seems to be a very effective way to deal with specifically Revlimid-induced diarrhea. So we can make this better. And I did this for somebody, and I remember her commenting to me, I went to Target, and I didn't think, where's the bathroom the minute I walked in? So this is all quality of life stuff. This is little things that you can do that make your life better. And then fatigue. So fatigue, whether you're on Revlimid, whether you're on any drug, it's one of the most common things that I hear that's a problem for people. You're on chemotherapy that makes you tired. You're on steroids that give you these energy up and down. You may have anemia. You may have chronic pain. You may be on other medications. There's lots of different reasons why fatigue does happen. And so, ironically, we're not going to say take to your bed and rest up, because that doesn't help. If you take to your bed and you stay there all the time, you know that old saying, use it or lose it. You're going to lose it. You're going to get weaker. And so while you may not be able to do everything that you once did, I do encourage my patients to exercise in a way that's appropriate for them. So stay active. The more you exercise, it might be hard to get out there and do that, but the irony is that you're going to feel better after you do it. Not necessarily a marathon, although we saw some pretty impressive feats from some of the myeloma patients earlier. There is a gentleman called the Myeloma Marathoner, by the way. He's in Minnesota. I read an article about him, and he's well into his 70s, and he's run a number of marathons since his diagnosis. So that's pretty inspirational. If you don't get to his level, you can still do something, whether it's walk, a gentle swim, some stretching exercises, but stay up and about and do the most that you can with your body. Eat a balanced diet. Try to eat things that are going to nourish you and going to give you more energy. And try to have some healthy sleep patterns. If you're having problems with sleep, if you're having problems with eating, bring it up and let's see what we can do. Don't rely solely on things like sugar and caffeine to give you that little energy boost. A little cup of coffee is fine, but we want you to have some good habits too. Kyprolis. So some of the things, I was just talking to somebody at lunch who finished their first cycle of Kyprolis and was reporting some shortness of breath. Shortness of breath is pretty common shortly after you get your infusion. So if you get this treatment, usually you'll get it maybe 2 days in a row, 3 weeks out of 4, or some people get it in a once weekly fashion. And sometimes that evening or the next day, they may feel short of breath or winded. So keep an eye out for that and report it if it's happening. There are different reasons why it happens. There's different ways we can sometimes work on it. Sometimes it's a problem, sometimes it's not such a problem. I want to talk a little bit about blood pressure and Kyprolis. A lot of people have high blood pressure anyway. When you go on Kyprolis, it may get worse. And this is something that you really do want to manage because it's important for your heart health. So keep an eye on your blood pressure. It may go up. Someone said down, so maybe some people's blood pressure goes down when they're on treatment too. But you want to see where it is. And you might have to adjust those blood pressure medicines. You might need more, you might need less. Some people get headaches or flu-like symptoms after they get their Kyprolis, usually in short order afterward. A small amount of steroid can actually be your friend in this case. If you get a little bit as a pre-med, it might help you out. If needed, we'll refer you to somebody. We'll refer you to a cardiologist or whoever we need to get you the help that you need. Dexamethasone, everybody knows it and loves it. I'm telling you to have good sleep habits, and then I'm saying, here, take your dexamethasone, and that doesn't always work, does it? Biggest things I hear about dexamethasone, it can make you tired, and it can make you energetic. So you might have a lot of energy for a few days, and then a few days after that, you're extremely, extremely fatigued. If you can, try to maintain some regular habits. Some people do better taking their dexamethasone at night. Some people may do better taking it in the morning, but I seem to find in my informal survey of patients that more people actually benefit from taking it right before bed. They go take it right before bed, and maybe they sleep through that first night before it really kicks in and gives them a hard time to sleep. Fluid retention can happen, and weight gain in general can happen with dexamethasone. Your blood sugars can go up, so if you're diabetic and you're on dexamethasone, that may be an extra thing that we have to deal with. And then mood changes. People can feel depressed, people can feel irritable. If someone comes in with their spouse, usually the spouse is the one to tell me if they're on too much dexamethasone. I had somebody move out to the casita, and I said, we have to reduce the dose of dexamethasone at this point. It can make you irritable. So if you're feeling more irritable, it's not just that you're a grumpy person, it's that dexamethasone might make you feel that way. It can cause heartburn too. I always tell people to take it with food and avoid things like NSAIDs, like ibuprofen along with it, because that can really be rough on your GI tract. Lifestyle enhancements. So anything that you can do to improve your quality of life. If you're drinking heavily, that's not a good thing. That's not going to help your body be strong as it needs to be to fight this disease. If you're smoking, that's going to be hard on you. It's going to make you more susceptible to respiratory infections. Minimize or eliminate stress. We can't always eliminate stress. We can't. And if you have myeloma or your family member has myeloma, you probably have some stress on your plate. But see what you can do to take good care of yourself. Eating well, exercising, doing things that you enjoy too. Taking care of yourself doesn't mean just doing bad things that people are lecturing at you to do. It means having fun. It means deciding what are my goals, what are my priorities, how can I make some things happen that make my life good. So take care of your emotional and mental self as well as your physical self. If you're having a hard time with any of these things, it says to have an optimistic outlook. Well, that's not to be glib, because sometimes it's hard to do. Sometimes people have depression, and that's an actual medical illness. It's a medical illness that's often made worse by stress. It's often made worse by things like pain and disease. So if you are feeling depressed, you talk to us about it, because maybe we can help you to feel better. We talked a lot about how we can kill plasma cells, and that's awesome. But the reason we want to do that is for you, so that you can live a long time and so that you can do good things while you're here and enjoy being here. So in summary, there's a lot of different ways that we can reduce some of the impact of multiple myeloma and its treatments on you. We want to treat bones, we want to treat your blood counts, and we want to protect your kidneys. And so make sure to bring up the side effects that you're having. Sometimes people say, I don't want to complain. That's not complaining, that's telling us what we need to know to help you the best. And that's what we want to do. Thank you.
Thanks, Angela. We have time for one question. And there were a lot of questions about bones. And do bone lesions heal? And if a bone scan is normal, do I need to continue Zometa? And after a transplant, how long do I need to be on Zometa?
Those are all good questions. So some of the questions are, if you have a bone lesion, is it going to heal? And the answer is, to a point, it's going to heal. When we first start treating people, sometimes I know before the first time we've reassessed them with myeloma labs if their treatment is working because they feel better. If you're in pain because there's active cancer eating away at your bones and we're killing it, you might start to feel better right away. That being said, you can have some residual damage. And so let's say we're doing a skeletal survey on you, and we did a skeletal survey on you 3 years ago and you had some lesions, and you've been in remission since then. We're still going to see that. We're still going to see signs where that myeloma has damaged your bone. And so if we look at that x-ray, it won't look exactly like the x-ray of someone who has never had that happen. But we will still have some healing. We'll have some meaningful healing in terms of your improvement. And so then the other part of that question was about Zometa, how long do we use? I think that's different for different people. A lot of times one of the rules of thumb is that we use maybe 2 years of monthly Zometa, and after that we sort of assess. So for some people, if they've had a lot of bone damage, they might need it ongoing, long term. People who have had no to little bone damage might need less than that. Sometimes at that point, if we do things like a bone density test, we can tailor your treatment based upon that. Sometimes we'll use it quarterly or twice a year. We'll use it on a less frequent basis, still to give you some protection, but hopefully with fewer side effects.